I'm back in Plenary Session Studios. I'm joined by Dr. Manni Mohhyudin. Dr. Mohhyudin is assistant professor at the University of Utah Huntsman Cancer Center, and he is an expert in all things multiple myeloma. Manni, it's great to see you.
Thank you for having me here, Vinay. It's good to be back.
It's good to have you here. You're a crowd favorite when it comes to multiple myeloma. So here I am in makeshift Plenary Session Studios. It's gotten a lot more contraptions all over the place as we move into the world of video. Manni, how have you been doing?
I've been doing great. I'm loving life here in Utah and
loving life in Utah, huh?
Getting settled in my new job, and it's good. It's scary. I've been seeing all these MGUS patients, and as a fellow, I would feel very comfortable being like, oh, this is just MGUS. And now as an attending, I'm like, I have to think very, very carefully. It's just a whole new layer of responsibility.
Yes, all the MGUS rests on your shoulders now.
It's a big burden, but yes, it does.
We're going to let's talk about myeloma in general, and then we'll record our next segment about the paper and we can release that on the date of. But let's talk about myeloma in general. Multiple myeloma is interesting. Historically, the definition of multiple myeloma was end organ damage, was CRAB criteria. But then your friends in the International Myeloma Working Group, they changed the definition a few years ago, didn't they?
That is correct. In 2014, the definition was expanded to include some cases with no CRAB criteria, but meeting some other parameters. So if the bone marrow biopsy, exceeded 60% plasma cells, or if the involved-uninvolved light chain ratio was more than 100, or if there were certain MRI findings as pertains to the bones. So it was, and this was before my time, but I think a lot of it was expert opinion and the consensus that beyond a certain point, it was felt that myeloma is inevitable, and if end organ damage is not happened yet, it will happen in the future. But again, high quality evidence backing those claims was probably not there. And we've all had in our practice those exceptions. We've had patients who've been stable for years with this same high plasma cell burden or high kappa lambda ratio, but they haven't had an organ damage. So yeah, it's been a little controversial, but it's mainstream now. It's called SLIM. So SLIM CRAB is now is what we use to define multiple myeloma.
Yeah, I agree with everything you said. The only thing I will add is I think in cohort studies that if you have these SLIM criteria, you do not all inevitably progress into multiple myeloma, even with extended follow-up, even with 3 years, 4 years follow-up. There is a fraction of people that do not progress, and we're treating them because of these new criteria. And I think the gold standard way to have validated their criteria would have been to a randomized controlled trial treating at the time of SLIM criteria versus at the time of the 85% or 90% that would eventually develop multiple myeloma. But they never did that study because apparently in the modern world, you don't need to do randomized trials as often as you'd like. Yeah, so that's what I have my bone with it. Now let's talk about melflufen. Melflufen is a great drug because it's entirely novel and we've never seen anything at all like it. Isn't that fair to say, Manni?
Well, it's a couple of small tweaks to a drug that's been there for a long time. So they've.
What's that drug? I've never heard of it. Melphalan. What is this Melphalan? I've never heard of it. I never gave it.
So they've tweaked Melphalan in a way that it has an aminopeptidase attached to it. It's more lipophilic. So they say, based on preclinical studies, that it's about 50 to 100 times more potent than melflufen. It sort of aggregates within the plasma cell and then releases its payload, and there's less toxicity beyond beyond the hematological toxicity that we see. So that's what they say, that it's 50.
It's easy to say all that when you've never tested it head to head against melphalan, right? It's easy to say.
or any other chemo for that matter. It's not just melphalan, Cytoxan or bendamustine or any other chemo. Right.
If you ran me and Usain Bolt on 100 meters, I mean, the way I run, the stride I get, it could, in many ways it's better than Usain. But obviously we've never tested head to head. You don't know what's better. You really don't know. It could be me. Yeah.
Right. Exactly.
Okay. So this drug was approved on the basis of an uncontrolled study with a single agent with a certain response rate. What was the response rate?
Yeah. So the response rate, I'm blanking on the exam, was 26 or 27. It was in the 20s.
Yeah. So not in myeloma, they say that's the benchmark. They call it the benchmark.
Right. So not an amazing response rate. The study was called Horizon. It was studied in a heavily, relapsed refractory population. And yeah, they saw some activity, in the ballpark of 25, 26% response rate. So then the FDA approved the drug based on this trial, similar to how the FDA has approved some other drugs for myeloma based on uncontrolled studies with similar ballpark response rates. And then what happened is that they did a randomized study, and this study is called the OCEAN study. So it's melflufen dex versus pom dex. And you and I have spoken extensively about how pom dex is not used anymore, and pom dex is a bad control arm. But the bar is low. So pom dex is a bad control arm. It's pretty easy to beat. You could argue that they should have probably chosen a chemotherapy-based control arm, not just like an alkylator, because like that's what you're trying to show, that this new alkylator is better than the old alkylator. But yeah, they chose pom dex. So what happened is, it's an interesting sequence of events that initially they came up with a press release that the study met its primary endpoint and melflufen was non-inferior to pom dex. And so so they didn't say that melflufen beat pom dex, it was just non-inferior to pom dex.
Yes.
And so that happens, and then a few weeks pass, and then in June what happens is that there's the FDA actually asked for some additional data because some data was actually missing. The sponsor had not provided all of the data required for analysis. So that is a little that's a little scary. So when they got the additional data,
pharmaceutical? No, just kidding. Shout out there for the geeks there. Okay, go on.
So when they got this additional data, they found out that melflufen actually did narrowly beat pom dex based on PFS. All right, but the OS was numerically much worse in the melflufen arm versus the pom dex arm. Now, data is very sparse, so we don't exactly know a whole lot of details. The companies is planned to present their findings at a meeting later this year. I think it's the International Myeloma meeting that they're going to present it at. But they're saying it was because of differences in subgroups between pom dex and melflufen dex arms. But I don't know if I buy that. The bar was set low. The drug still had a lot of hematological toxicity, even though they say that it sort of stays within the plasma cell. And with all of these other new things coming out, there's really isn't much of a role for melflufen anymore. The other tragic aspect to this piece is so they designed. So how you and I have spoken very passionately about 2 drug versus 3 drug trials and how they really shouldn't be doing them anymore, right? When you say triplets are what you should be giving, then why are you designing a doublet trial? Right. But what happened is that they opened a randomized study called the Lighthouse study, and this study actually enrolled. It was open at 3 centers in the United States, and so we were talking about 3 versus 2. This was a 3 versus 1 study. So basically, one arm gets daratumumab monotherapy, and then the other arm gets dara plus melflufen plus dex, and it's powered for PFS. You tell me what meaningful answers can we get from such a study? Wow. And you're giving patients who could otherwise get on other trials, these patients could get CAR T. Outside of a trial, these patients would at least get triplets, and you're giving them just dara monotherapy in their control arm in the United States. Criminal. So that's a travesty. And Aaron Goodman and I have been pretty passionately advocating against this, and it took worse overall survival from a previous study to finally halt this Lighthouse trial. So the Lighthouse trial has now been suspended for enrollment, which is good for our patients, but it's a tragedy. So trial. Yeah, 3 versus 1. Like, what kind of answers would you get? Like, obviously, if you have 3 drugs with per se activity, exactly, you're going to get a better response. They're going to lower the M protein more, but that is not the answer that's meaningful to our patients or to us for that matter.
A few thoughts on these topics. One, Horizon, Ocean, Lighthouse. What are they, on a vacation at the beach when they're coming up with these names? What the hell's going on? And the next thing should be called Selective, because you randomize patients to melflufen, cytoxin, melflufen, daratumumab dex, versus just being shoved off the side of a Selective, which is really the quality of their control arm. So that's what their Selective is, their next one, I suspect. And then maybe washed up on shore or low tide. I don't know where they're going with these melflufen studies. Next thing I'd say is, we always talk about response rate in quote unquote heavily pre-treated patients. And of course, the people who enroll in these studies often have progressed through many prior lines of therapy, 7, 8, 9, 10, 11 prior lines. I think I've seen 15 in one, 15 prior lines of myeloma therapy. Okay, and there's a lot of debate on what really constitutes a line. But I think we forget that another way to put that is these are people who met eligibility criteria and have lived long enough to have endured 7, 8, 10 prior lines of therapy. That biology is really indolent growth of that plasma cell clone. I mean, in many clinics, we don't have people live long enough to experience that many lines of therapy when myeloma takes off, when it really becomes rip-roaring myeloma. So in a lot of respects, generating this response in this highly curated cohort, it doesn't necessarily mean you'll get that response rate in my clinic if I start to use it.
Correct.
So that's one point. Yeah, and then the next thing I want to, unless you want to say something about that, say something about that.
Go ahead. I don't want to interrupt you. Go ahead.
No, I guess the next thing I want to say is about this, like the pressing need for randomization. And Oceans shows you that I guess I have not yet seen, and maybe you know, that many of the people who receive Palm Dex have probably already received IMID and probably already received Palm. I don't know that to be true, but is that true? You have to be Palm.
So I don't think that they had received Palm, but they definitely had received, the both of them had received lenalidomide
and had all of them seen Melphalan in auto setting?
No, so not all of them had a prior transplant.
Yeah, so some of them may have never seen alkylators.
Correct, and the responses were better. So based on press releases, the subset it works best in are those patients who've never seen an alkylator.
Of course, yeah.
Exactly, who are going to respond to, they would have responded really well to melflufen or...
Yeah, they're going to respond to an alkylator, yeah. So
Exactly.
give them an alkylator like Cytoxan or Melphalan, I think we've seen this before. I remember that that randomized trial of like venetoclax rituximab versus bendamustine rituxan in people who've already seen Benda, or carfilzomib dex versus Velcade dex in people 60% had already gotten Velcade, So like, of course, a class of drug you've never gotten or a specific molecule you have not yet received will outperform giving the same class or the same drug over and over again, but it's not really an intellectually rigorous question.
I so agree.
Yeah. This is a tough space. Yeah.
It is a tough space. And sort of echoing on what you said, so, those patients who make it to that many lines of treatment, they are a selected population. If you look at, this, large data sets, on average, people make it to about 3 to 4 lines of treatment. So those who make it beyond that are a selected population who got there. A lot of our high risk patients, they just, relapse quickly and then they don't make it to these advanced treatments.
This is another side point you make me think about. You point to the real world data, which is that people often can only live long enough to be treated with 3 or 4 treatments, which speaks to the nature of the biology. But then some investigator runs a randomized controlled trial of exquisitely chosen patients, and they say, we didn't have post-protocol care. It was very poor. But as you well know, only, some small percentage of people make it to 5 lines of therapy or something like that. And what I want to say is that's a statistic that comes from average people in the clinic. But the people you enrolled in your study, those are not average people. You have picked the people who could have easily gotten 5 or 6 or 7 lines of therapy, and you've deprived them of subsequent lines of therapy. That is a tragedy. So I see that all the time with these, bladder cancer trials that are all.
And that's true in myeloma trials as well. That speaks to my soul. And you and I have done work on this where we've shown that, about half of patients in myeloma randomized trials go on to receive subsequent therapy. And these are highly fit patients going to, institutions where they can get, more treatments. And, we've shown that when they do get treatments, those treatments are suboptimal. And it's pretty messed up. Just along those same lines, where there was an editorial published recently in JCO about Ixazinib Lendex versus Lendex in the relapse refractory setting, and how the triplet of Ixazinib, tourmaline, and how the triplet actually did not show an overall survival advantage over the doublet, because post-protocol therapy was transparently reported. People just got people got more effective drugs at some point in the disease course. They got more effective PIs. They got daratumumab. So it negated whatever, minor effect Ixazinib.
And Ixazinib is the shittiest proteasome inhibitor. Let's also add that to the mix, right? Oh, and I remember they had that quote from The Princess Bride, which is, something like, I don't think that means what you think it means. And then they use that to mean something that I don't think they know what it means, what they think.
It was very disturbing. Honestly, it reminded me of an apocalyptic movie, not like The Princess Bride. I was like, this is apocalyptic. If we neglect overall survival in our interpretation and we come up with all of these weird excuses to sort of justify it and say that overall survival is meaningless. And honestly, that article, I would say, aged very poorly, because you get this editorial that says OS doesn't matter. And then a few weeks later, you have this melflufen fiasco and OS does matter.
OS does matter.
Without OS, you wouldn't have known that melflufen was, bad for our patients.
You wouldn't have known about venetoclax in myeloma. You wouldn't have known about Pembro without OS. But the other thing I want to say about this that really struck me is one of the points the authors were making was what Ixazinib Revdex versus Revdex. The Ixazinib did not add OS at the end of the day. It failed to show an OS benefit. Right. And so they were saying, well, it's unrealistic to expect it to show an OS benefit. I was like, well, what about all the other drugs in this space? Carfilzomib, it got there. Dara, it got there, and so why is Ixazinib getting, all the other drugs were able to achieve it with subpar post-protocol therapy, of course, right. But your Ixazinib couldn't even get there. It speaks to, I think what many of us believe, which is Ixazinib is, it's the drug that you think about when you are done thinking about the other drugs. Is that fair to say?
Right. Yeah. There are just some theoretical situations where one would consider it, where you strongly prefer an oral drug, but even then it's really suboptimal. And this entire premise of, the oral drug being better is, I think it's a pharma ploy, and it comes with a lot of caveats. Like, they say selinexor is all oral, but you need to schedule patients for IV fluids and give them, IV supporting medications and medication to support their platelet count. It sort of negates whatever the oral benefit you're getting from selinexor.
They should keep a shelf in the pharmacy. Here's what I'm going to put on my shelf, the myeloma shelf. I'm going to put Elo right down there. I'm going to put selinexor. I'm going to put panabinostat, and I'm going to put Ixazinib on that little shelf. I call that the shelf that you don't really need to use that often. That's the shelf. Okay, right. And then I'm going to put belantamab there too, because I'm not the eye stuff, and we're going to easily surpass it in the next year with better BCMA-directed therapy.
Right. So I think until BCMA, if you ask me, if I had to choose between belantamab, melflufen, and selinexor, I would choose belantamab.
Okay, that's like asking me to choose your favorite dictator. Who's your favorite dictator? I don't know.
But I completely echo your thoughts, where once we have better BCMA, safer BCMA drugs that are easily accessible, belantamab is going to have a very limited role. And it's a very tough sell. This ocular toxicity to patients, it's a very tough sell. Like at our institution, when I was at the University of Kansas, we were trying to recruit people for earlier belantamab therapies, for newly diagnosed and first relapse. And nobody would enroll for it, because you tell them these scary toxicities. If you tell them honestly about them, they're not going to enroll. I wouldn't enroll my father or myself on, there was a chance of, losing my eyesight, even if it's temporary, when there's so many other good, effective treatments available.
Doesn't make sense.
Exactly.
And even the ophthalmologic visits alone, it's just a big headache.
It is cumbersome.
Okay, the last thing I want to talk about before we talk about our paper in a separate segment that we're going to release on the date of the paper, the last thing I want to talk about is, there are so many ongoing BCMA or other CAR T trials in myeloma. I'm not sure I see a value to moving CAR T up early in an uncontrolled study. What am I learning? What am I learning when I give induction chemotherapy and then just give CAR T and then give auto if it fails? If there's no randomization, what am I learning by giving a drug that I know is active? I know ide-cel is active. By giving it earlier, I don't know if I could have given it later. Why are we doing uncontrolled trials and moving active CAR Ts earlier? That's the question.
Right. So that's a good question. And I agree with you that the benefit of an uncontrolled trial is limited in that setting. Let me give you the counter argument. So there are controlled trials happening as well in this space. And I want to sort of highlight their flaws, because they have big flaws as well. So there's a trial of cilta-cel, where cilta-cel is being evaluated, and essentially it's being evaluated in transplant, in patients who are not intended for early transplant. Okay. And that's a very vague term. And that essentially means that, these patients probably might have gotten transplant off of a clinical trial. So what happens is, in one arm, patients get, VRD, and then they get put on len maintenance. So you're de-escalating just to lenalidomide, all right, after 8 cycles of VRD.
8 cycles of VRD and then 2 years of len.
Correct. Okay. And then the other arm gets VRD followed by consolidation with cilta-cel. Okay.
And then they get Revlimid.
Yeah. Well, I don't think that you get Revlimid after that. Yeah. So, and you're powering this for PFS. So first of all, I feel like the true comparison, the true question, if you want to move it up front, you got to compare it to an auto transplant.
Of course.
That is what we do for fit patients. This is what we do.
And if you're fit enough to take a cilta-cel, you're fit enough to get an auto.
Exactly. So that is what I find deeply problematic with this. And if cilta-cel truly is that good, then we'll, it'll, in a randomized trial, you'll show that it has, it's safer and it's might produce better remissions. But that's we're not going to find that out here. So we're still going to be left in this, conundrum about whether to do a transplant or whether to do CAR T for an eligible patient. So that is very problematic. But at least, there are some studies that are randomized with all the problems in that space. Now there are.
If it was not cilta-cel but ide-cel, then I think it would still be. I don't know who's going to win that. If it was ide-cel, I really don't know. Maybe Len will beat it. That tells you something. Right. Okay. Right. Okay. Now what else you got? Yeah, that's an interesting point.
Yeah, and then you can make a case that, and again, you can randomize. You can do randomized trials even in high risk myeloma. It's been done before. We've done ELO VRD versus VRD. But I think the current paradigm or the current thought process for most of the leaders in the myeloma community is that they're doing a lot of small phase 2 trials with novel concepts for high risk myeloma, which, I mean, I get treating high risk myeloma differently. I think we know that they haven't really done all that advances. So yeah, so there are some concepts and some trials out there where they're doing CAR T in an uncontrolled fashion in an earlier setting, but that's just for high risk disease, which it's a subset of a population. Ideally, we should still have randomized those patients, but I get the concept. I mean, I get trying to come up with sort of newer approaches. But for standard risk myeloma, I agree. Like if you're giving them CAR T earlier, it should be in a randomized setting.
All right, let me push back on this a little bit because I agree with, we agree on the standard risk. The high risk thing, I don't know, this is just this thing in heme malignancies. We just do it in heme malignancies more than other fields. Right. In DLBCL, we get all worked up about MYC. And so we got to give EPOC. If you find a MYC, you give an EPOC. If it's a high-grade B-cell lymphoma, maybe you should give an EPOC, instead of CHOP. And then we do, a nice randomized trial to CLGB. And of course, they're just stone cold negative study. It didn't do, EPOC doesn't do anything better than CHOP. But then we say, well, in this subgroup, they do worse with CHOP, comparing some historical subgroup against some cohort that's absolutely different because they were treated at top centers, in this coordinated fashion. And we say, well, EPOC's better. Then they get the Flatiron data this year by Gaurav Goyal, and it shows that, they're stone cold the same in MYC rearrangement. And now in myeloma, you've got your high risk and everyone wants to give dual PI, Revlimid maintenance. And in fact, the big debate in there is, do you give him carfilzomib Rev or do you give him the bortezomib Rev? I mean, and I was like, nobody has randomized yet. And I will be honest with you, here's what I think the real root of all this is it's like a field that has not yet there's one thing to understand that randomization can give you counterintuitive answers, but it's another thing to internalize that. And when you internalize that, you really are uncomfortable, I think, making proclamations about randomization. And it's easy to think worse disease needs more drugs, but we thought that before in other tumor types, and we screwed up big time. And so I think randomization is the only way out of it, but we are in a moment of crisis. I see in randomization, every time I suggest that there's something that can be done in a randomized fashion, people tell me that millions of reasons why you couldn't do it, all of which reveal that I'm not sure if they've really read more than 2 randomized trials in their life. I mean, I don't think they know anything about it, but okay, but be as it may. That was a fair summary. Our time's gonna run out. So we're gonna stop this dialogue. We're gonna shift gears and talk about our paper in press. But you've been listening to Manni Mohhyudin. Stay tuned for a future segment where we're gonna talk about a paper we have coming up on CAR T, and no spoilers here. So thank you for doing this, Manni.
Oh, my pleasure, thank you.
Okay, let me